Hello, and welcome to CRPS Contender, my complex regional pain syndrome education channel. Today's video is My Chest Hurts, and we will be taking another step down our journal journey. Today's paper is Atypical Chest Pain, Evidence of Intercostobrachial Nerve Sensitization in Complex Regional Pain Syndrome, written by Doctors Rasmussen, Grotherson, Rosso, and Schwartzman from Drexel University College of Medicine in Philadelphia, Pennsylvania. This was published in Pain Physician in the September-October 2009 edition. I'm going to be reading from the overall purpose of their paper here. What's written on the screen is pulled directly from their paper. If you hear any inconsistencies or exchanges of words from what's on the screen versus what I'm saying, that is for the purpose of making it more understandable. But what is on the screen is actually pulled directly from their paper. And of course, if you would like to see the paper itself, all of the images that I use in this paper and the paper itself will be linked directly in the sources at the end in the description below, if you would like to see that for yourself, as always. Atypical chest pain is a common clinical problem faced by internists, emergency room physicians, and cardiologists. Atypical chest pain most commonly presents in young women. Non-invasive screening tools for atypical chest pain, such as stress EKG, are less specific in the female population. This leads to an increased number of referrals for a procedure that uses x-rays and catheterization and a specific kind of dye to see if there is a restriction of blood flow to the vessels that supply the heart with blood to give these patients the definitive diagnosis. If so, these patients can be provided with a stent in their heart. Approximately 25% of performed coronary stents are normal. CRPS occurs primarily in young women, age range 36 to 42 years, with a ratio of 4:1. It is defined as chronic pain disproportionate to the inciting event, with associated sensory abnormalities of hyperalgesia, mechanical and thermal allodynia, and hyperpathia, autonomic dysregulation, motor symptoms, and atrophy and dystrophy. CRPS typically begins in one peripheral area and then spreads coming up the body in a mere distribution and may generalize. It frequently sensitizes nerves with the affected area. Although the pathophysiology isn't completely known, central sensitization and glial activation of the spinal cord appear to be prominent features. The glial cells are your nervous system's immune cells and support cells. The purpose of this paper is to describe a common cause of atypical chest pain, more frequent in women, that may arise from irritation and sensitization of the intercostobrachial nerve. The authors had noted that many CRPS patients complained of chest pain, which the patients themselves did not think was related to their chronic pain condition. Many of these patients had sought out and received extensive cardiac workups, usually ending with negative angiograms. We hypothesized that patients with CRPS from brachial plexus injury, which is the nerve bundle that controls your arm and is right around your armpit area, that's where that brachial plexus is, might have chest sensitivity that could result in atypical chest pain secondary to sensitization of the intercostobrachial nerve from its brachial plexus origin. So before we move on to the rest of these slides, I just want to show you what the intercostobrachial nerve looks like and where it is so that you kind of know what we're talking about if you're not familiar with what it looks like or where it's located. On the image on the left here and in the upper right corner, you can see it from the front, and in the lower right, you can see the area that gets sensitized for figure 1, image 3. This is actually an image that I pulled from the paper itself. Image 1, in the left side of the screen, you can see that the nerve runs up through the armpit and then comes down the arm, where if your arm was resting against your rib cage, it would actually be the part of your arm that's resting against your rib cage. That's where that runs. And if you're looking at image number 2, you can see T2 there. That is where the intercostobrachial nerve leaves your spinal cord and then runs to the armpit from there. even though this image is also from a front view where you're looking at the sternum, it has the vertebrae superimposed so you can see where it would be aligned. But that bone that you can see over by the shoulder there, that's actually the clavicle. And all that muscle over by the green arrow is the pectorals. And then in image number 3, you can see the sensitization skin distribution of that entire nerve, which is covering the pectoral area and the inside of the upper arm. Now that that's covered, let's move on. Taking from the abstract here, talking about the purpose of this, some of the limitations, the results, and the conclusion. This is a quick overview of the entire paper. Atypical chest pain is a common complaint among CRPS patients with brachial plexus involvement. Again, that is the nerve that controls the arm. Anatomically, the intercostal brachial nerve is connected to the brachial plexus and innervates the armpit, the inner arm, and the front of the chest wall. By connecting to the nerves that control the arm, the intercostal brachial nerve could become sensitized by CRPS spread and become a source of atypical chest pain. The objective of this paper is to evaluate the sensitivity of chest areas in CRPS patients and normal controls. Limitations of this paper are a relatively small number of patients and controls used, which is 35 CRPS patients and 21 controls. The results: a history of chest pain was reported by a majority, 94%, of CRPS patients and a minority, 19%, of normal controls. CRPS patients reported that lifting their arms was a major initiating factor for chest pain. Pressure algometry, which is using a specific tool that can measure how much force is being applied to a specific area, which then the patient can say when it starts hurting them. The ratios of CRPS patients were significantly greater than control subjects, indicating increased chest wall sensitivity. Conclusion: the results of this study support the idea that chest pain is greater in CRPS patients than normal controls, and the intercostal brachial nerve could be the source of this sensitization by CRPS spread from the brachial plexus. Let's talk about the methods used in this paper. Inclusion criteria: 40 patients who met all criteria for CRPS from the International Association for the Study of Pain. Patients were receiving individualized treatments that generally included pharmacological mono or combined therapy with non-steroidal anti-inflammatory drugs, tricyclic antidepressants, anticonvulsants, and, if necessary, low or high-potency opioids. People were excluded if they had undergone IV ketamine or lidocaine infusion in the last 3 months, if they had undergone a mastectomy, a major surgery, or a severe chronic illness within the last 3 months, or if they were pregnant or lactating. 4 CRPS patients were excluded, and 8 did not complete the study due to secondary pain or time constraints. Subjects were only included in the analysis of the study portions that they completed. There were 21 control subject volunteers. The exclusion criteria were any history of chronic pain disorder, spine surgery, use of narcotic pain medicine 1 month prior to the study, a major surgery or medical illness, and females who were pregnant or lactating. All subjects were asked if they had presently or ever suffered chest pain, its location, quality, and radiations, its duration, if they had ever been examined by a physician for the chest pain, the diagnostic tests they had attained, and the final diagnosis. Quantitative mechanosensitivity was measured at multiple chest sites and the abdomen. They used 10 specifically. To control for individual differences in overall pressure sensitivity, we divided each chest result by abdomen result. The rubber tip was placed over the appropriate site, and continuous pressure of 1 kilogram per second was applied until the subject reported discomfort, or a pressure of 4 kilograms per centimeter squared was reached. If no discomfort was expressed, at a maximum of 4 kilograms per centimeter squared, a value of 4.1 kilograms per centimeter squared was assigned. Similarly, if a patient could not tolerate pressure for a minimum of 1 kilogram per centimeter squared, which was the minimum value detected by the instrument, a value of 0.9 kilograms per centimeter squared was assigned. Sensory radiations were also measured during the pressure algometry. Subjects were asked to report sensations of pain or tingling distant from the pressure algometry testing sites. Values of 1 indicate equal sensitivity of the chest and the abdomen region. Values below 1 indicate a higher sensitivity at the chest compared to the abdomen. Now, look at table number 4 over here to the right of the screen. Notice all of them are below 1, which means the chest was more sensitive than the abdomen in every category. But I specifically have 4 of them pulled up here because these are the lowest 4 rankings, which means they were the most sensitive. There were 2 that are listed at 0.48, 1 that's at 0.50, and 1 that's at 0.52. These are very sensitive areas. This is the left armpit, the left second intercostal space, the right armpit, and the left third rib. So what these areas are is going to be the area, specifically both armpits, and then the area that's right over the heart, which you can there see how someone would assume that this is a heart issue if you're having an extremely sensitized nerve that's right in that area, causing you extreme sensitivity and pain. Results. Demographics. There is no statistically significant difference between genders in each group. There was a statistical difference between the control and the CRPS ages of 36 years versus almost 46 years, but the analysis indicates that this did not correlate with the results. Clinical characteristics. 94% of CRPS patients reported a history of chest pain, while only 19% of the control subjects reported ever having chest pain. The majority of chest pain reported by CRPS patients was bilateral in 66%, above the breast in 79%, deep in nature in 60%, radiating to their jaw, head, or neck in 52%, and radiating to their shoulders or arms in 46%. The major initiating factor for this chest pain in CRPS patients was lifting their arm in 65% of these individuals. CRPS patients primarily sought care either in the emergency room, for 26%, or from their primary care physician, for 40%. The majority of CRPS patients seeking care for their chest pain presented to their PCP, and they received an EKG, almost 80%, or were diagnosed with unknown chest pain origin, 26%, inflammation of the cartilage that joins your ribs to your sternum in 21%, or psychosomatic chest pain in 21%. 33 CRPS patients and 21 controls completed the pressure algometry part of the test, and CRPS patients were significantly more sensitive in all chest sites compared to their abdomen than the control subjects. As far as the sensory radiation aspect, 40% of CRPS patients reported sensory radiation upon pressure testing compared to 5% of controls. No radiations were reported when testing the abdomen. The majority of radiations occurred after testing the second intercostal space, and 42% of the CRPS patients reported this, with the 10th rib and sternum receiving the fewest reported radiation, which was just 30% of the patients. The intercostobrachial nerve arises from the second intercostal nerve, which comes from T2, with a highly variable contribution of the T3 and T4 nerve roots. Upon exiting from the second intercostal space, the intercostobrachial nerve innervates the armpit and the part of the arm that rests against your rib cage when your arm is down. In addition, the intercostobrachial nerve contributes to the innervation of the outside of the forearm, the part of the forearm that aligns with the back of your hand, via connections with the posterior antebrachial cutaneous nerve and contributions to the upper anterior chest wall, secondary to connections with the long thoracic nerve. Occasionally, it has been reported connections to the pectoralis minor and major muscle, which is your chest muscles. 30% of the time, the intercostobrachial nerve is directly connected to the brachial plexus, which is again that bundle of nerves that controls your arm, primarily via the medial cord. Recently, it has been demonstrated that T2 has a connection to the brachial plexus 100% of the time, 80% via the intercostobrachial nerve and 20% from the direct intrathoracic connections. Since T2 is the primary root of the intercostobrachial nerve, it can be assumed that the intercostobrachial nerve has connections to the brachial plexus. The chest pain described by CRPS patients typically occurs above the breast and radiates to the jaw, face, shoulder, and arm. These pain radiations are similar to those described in cardiac chest pain. These radiations are within the territory of the intercostobrachial nerve through its connections to the brachial plexus. The authors suspect that this pattern of pain radiation could occur with any cause of intercostobrachial nerve sensitization, including CRPS. This study demonstrated that 94% of CRPS patients reported a history of chest pain versus only 19% of controls. Half of the CRPS patients that reported chest pain were concerned enough to seek medical care specifically for the chest pain. That included a cardiac workup. 84% of these cardiac workups were negative. CRPS patients did not relate their chest pain to their pain condition. Sensitization in the territory of specific nerves is a complicated process. It is initiated by nerve injury and consequent increased excitability of pain transmission neurons throughout the central nervous system due to synaptic plasticity. There is naturally accompanying nervous system immune glial activation at both the segmental level, which is the nerve that comes off of a specific nerve root from the spinal cord, in a mere distribution, and at levels above and below the level of injury. It is a dynamic process that often spreads from the site of the original injury. The chest pain described by the CRPS patients is possibly caused by sensitization of the spinal cord dorsal horn neurons that subserve the intercostobrachial nerve, and it has similar qualities to coronary artery disease pain. Only 40% of our patients described their chest pain as burning, which is typical for neuropathic pain, while 60% described it as deep. This may be one reason why most CRPS patients did not relate their chest pain to their typical CRPS burning pain. An interesting observation in this study was that 65% of the CRPS subjects reported being able to elicit chest pain by raising their arms. This suggests that stretching the brachial plexus might place traction on the intercostobrachial nerve and induce the constellation of chest pain symptoms. It has been shown in experimental animals with nerve injury that somatic mechanical sensory may take on the expression of pain fiber markers and activate dorsal horn pain transmission neurons. The pressure testing results indicated that all subjects were more sensitive to pressure in chest areas than in the abdomen. This would be expected since there is more sensory innervation to the chest wall than the abdomen. However, CRPS subjects were significantly more sensitive in all tested chest areas than control subjects, demonstrating increased pressure sensitivity in the territory of the intercostobrachial nerve. Conclusion: sensitization of the dorsal horn spinal neurons in the territory of the intercostobrachial nerve can cause severe and clinically relevant chest pain. The pattern is similar to atypical chest pain, frequently thought to be of cardiac origin. Future studies are needed to evaluate whether cardiac chest pain produces the same chest wall sensitivity to pressure as seen in our CRPS atypical chest pain population. This would further clarify the role of muscular and below-the-skin innervation by the intercostobrachial nerve in the anterior chest wall, and could possibly reveal whether pressure testing could be used to help rule out non-cardiac chest pain. Our results indicate that sensitization of the sensory dorsal horn input from the intercostobrachial nerve should be included in the differential diagnosis of atypical chest pain. It could prevent unnecessary extensive and possibly invasive cardiac workups. A major clinical clue is chest pain induced by raising the arm. Thank you for watching. As always, relevant sources, including the images that I used in this video, are going to be linked in the description as well as the notes that I took. If you would like to support my content creation or visit my website that is listed here. It's also going to be listed in the description below. If you appreciate what I'm doing here on this channel, please engage the algorithm in some ways to help others who also would benefit from this information find it through all of the content that is here on YouTube. That would help me out a lot. Thanks so much for watching. I hope you learned something today, and I hope to see you next time.